after the nice talk by Dr. Shushmita, I'll be talking on a different subject. It is keratoplasty with cataract, different situations. So I have no financial disclosures. So the triple procedure, that is combined keratoplasty with cataract extraction and intraocular lens implantation, is a well-established and effective surgical treatment for patients with both corneal and lenticular opacities. It was first described by Taylor in 1976, and since then the procedure has evolved considerably. If we talk about the advantages of triple procedures, triple procedure helps in prompt visual rehabilitation, protection of transplanted endothelium, superior functional results following triple procedure, no need for second surgery for visual rehabilitation, and it is also economical. Although there are certain challenges involved in this procedure, like difficult surgical technique, cortical removal is especially challenging in such cases. High posterior vitreous pressure is the main thing that causes all the trouble in open sky cataract surgery. The problem in intraocular lens power calculation, because the cornea is very bad, so you don't get the exact power in most of the time, so you have to take the other eye's values. And intraocular lens implantation due to high vitreous pressure is challenging sometimes, and after all the efforts, sometimes results are unexpected. So the indications for cataract surgery with penetrating keratoplasty is if the cataract is visually significant, or there is corneal perforation with lens plastering to the cornea, there is a high vitreous upthrust, ruptured anterior capsule, subluxated cataracts, and intraoperative lens damage. So this is a study done by Dr. Sridhar et al. From LVPI, and he has shown that the main indication for cataract surgery is corneal scarring with cataract in 69 cases. And if we talk about the problems occurred during the surgeries, vitreous upthrust in 7 cases was noted, and PCR in 3 cases. And in the post-operative period, the main concern was increased IOP in 19 patients and increased AC reaction in 25 cases. Although he concluded that this is a safe and surgical procedure with good graft clarity and reasonable visual recovery. This is another study in which similar result has been shown. So if we talk about pre-operative preparation for such cases, we have to look for the lens status, how severe is the cataract, any sign of peripheral anterior synechiae, look for phacogenesis or lens subluxation, check the IOL power. If involved eye has a bad cornea, then IOL power can be calculated in the other eye after checking the axial length. So intravenous injection mannitol is mandatory for all triple procedures, and the standard dose is 3 to 5 milligram per kg body weight. Alternatively, tablet acetazolamide 250 milligram, 2 stats before the surgery can be given. Good ocular massage is must for these cases to reduce the posterior vitreous upthrust after the local anesthesia. Although in perforated cornea, we should not massage and give the block in multiple steps. And pupillary dilatation with mydriatic should be tried in all cases. So this is one of the case in which you can see there is a dense infiltrate with the central corneal perforation. So Fleringer ring is another very useful device for all open sky surgeries, especially if you're going to combine with cataract surgery or in therapeutic cases. So Fleringer ring is applied in this case also. You can secure it at 4 points with Weichel sutures. Then after the trephination, just see the adhesion. The cornea is very edematous, and as soon as I removed the cornea, the lens has popped up because of the ruptured capsule due to the infection. And simply you have to lift the lens. So it's always better not to put lens in cases of therapeutic keratoplasties, or if the capsule is not very clear, because in the bag implantation is not possible in such cases. So irrigation aspiration cannula usually don't work very well in open sky surgeries. Gently you have to keep injecting saline, loosen the cortex, and Simcoe cannula works very well in all open sky cataract surgeries. And then measure the graft and put the new cornea back and wait for the recovery, and then go for secondary IOL. And after completing the surgery, the flaring ring is removed. So this is another surgery with the corneal scar, not that bad, with cataract surgery. And combined triple procedure is planned for this case. So rhexis is done. I prefer cystostome in all these cases. The chances of rhexis extension in these cases are very high. So we have to be very careful while performing rhexis. And then gentle hydrodissection is done and lens is popped up. Simcoe cannula has been used. The main problem that I faced with the bimanual irrigation aspiration is the reflex of water so much that you cannot see where the cortex is. So Simcoe works well. Hard PMA lens usually works very well in all cases of triple procedure because they're very hard and they stay beneath the capsular margin. Single piece IOLs are sometimes difficult to place in the bag. And then surgery is done. Next case. So another challenging situation in triple procedure is a small pupil because most of these cases are inflammatory eyes, and so there is a chronic inflammation. Many times atrophic iris patches, iris sphincter damage, posterior synechiae, peripheral synechiae. So performing rhexis in these situations are a challenge. So these two devices I regularly use in all my cases. First is a Malungin ring, other is a Zepto, and these works very well in open sky cataract surgery. So Zepto, most of us know about Zepto. Zepto is a precision pulse capsulotomy, and this makes 5.25 millimeter rhexis in a standardized fashion with a flexible suction adapter in which a nitinol ring is placed. The rhexis is always circular, fixed size, repeatable in all cases. In comparison to femtosecond laser, Zepto rhexis is stronger and economical for patients as well as for the hospital. So this is another case of dense corneal scar with vascularization. So trephination is done, and you can see the iris pupil is not dilating. So I tried viscodilatation also, but it didn't help. And with Zepto, you can gently sweep in beneath the iris without damaging the sphincter. The cup of Zepto is very soft; it don't damage the capsule or the iris. So gently you have to tuck in, and once you are sure that it is beneath the iris and in the center, then gently press the button, and it will take 1 second to do the rhexis for you. And it's done. And then lens is placed and graft is attached. So I published this technique also, and this is working very well in my hands. Another technique is a pupil expander. So normally we use this device in cataract patients, but it also works very well in open sky cataract surgery. It provides a stable interchamber because it presses the iris. So vitreous upthrust is also reduced with this device, and you get the good rhexis in all cases. So how to use this device? After removal of host cornea, Malungin ring is loaded into the injector and engaged into distal iris portion first, then subsequent lateral sides of the iris was engaged, and the last proximal iris is engaged. After confirming all the engagement of all the scrolls are secured behind the iris, CCC is performed. So this is a surgery. You can see I tried dilatation, but it didn't help, and then Malungin is placed. Many times cataract is so bulky that it's not possible to take it out from 2 millimeter. Just see the bulkiness of cataract. It's black cataract, and all the maneuvers are easy, removing the epinucleus plate, cortex, putting the lens behind the rhexis, and once everything is done, this is removed. So this technique was found safe and effective in all cases that I'm doing from last 3-4 years. Adequate pupillary dilatation was maintained throughout the procedure. No intraoperative or post-operative complication was seen in any of the cases done with this technique. If you have to combine cataract surgery with therapeutic keratoplasty, it's ideal to avoid cataract surgery along with therapeutic keratoplasty because chances of going infection into the posterior segment and rate of post-operative inflammation is very high in all these cases. Increased IOP post-operatively, and PC, if there's a PC rent by any chance, risk of endophthalmitis is also there. And now people are doing cataract surgery with DSEC. So basically this is a new triple surgery. Most common indication is fugue endothelial dystrophy. Cataract surgery is performed before DSEC lenticular insertion, and we should avoid PC rupture intraoperatively because that will affect the lenticular attachment. So in conclusion, triple procedure is good and safe surgical options if all the preoperative and intraoperative precautions are well taken. Zepto and Melugan ring are useful devices in cases of a small pupil in open sky cataract surgery. Dilatation provided by these devices helps in formation of capsular excess, extraction of cataract lens, and IOL placement in the back. Thank you.
Thank you, Bhupesh, for an excellent talk, and it is very elegant videos, and you have covered the entire spectrum very elegantly. Thank you so much. And if there are any questions, one question we can take while our next speaker loads his presentation. And our next speaker, I would like to invite Dr. Sudesh Arya for his talk on AMG in ocular surface disorders. Dr. Arya, please. Any questions for Dr. Bhupesh? Okay, Bhupesh, I had one question. So what about the anesthesia? Because once we have open globe, it's always a very difficult situation for the surgeon. And surgeon is always having palpitations. So do you prefer GA or prefer LA, or what would be your comment on that?
As a routine, we always do LA. Although GA is ideal for all these PK patients, but sometimes finances and all those things you have to look after.
Logistics.
Definitely pediatric has to be in GA, but adults we always go for local only.
Thank you.